Good evening and welcome to your recorded lecture on fluid and electrolytes. So first, to understand the concept of fluid and electrolytes, the balance is the process of regulating the extracellular fluid volume, body osmolality, and plasma concentration of your electrolytes. Now there's a whole mess of things that impact this in a variety of different ways, and we will explore some of those. Now, our normal physiology, uh, we have our maintenance of our homeostasis. So, our body fluids and our electrolytes play an important role in maintaining our stable internal environment. Body fluids are in constant motion, transporting nutrients, electrolytes, and oxygens into cells, as well as carrying away waste. Okay. Now, our composition of fluid and electrolytes is really kept within narrow limits, and we'll explore a couple of our electrolytes. Our exemplars are going to be sodium and potassium, but our fluid balance itself, we can be very dry, um, we can be dehydrated, which is different from a deficit, or can have an excess of fluids, which changes our osmolality and actually impacts our electrolyte balance. Now, water content varies with age, gender, and fat distribution in the body. Uh, the more fat in the body, the less total water content, which is why water intake should be based on body weight. And then women generally have a lower percentage of body water than men. Now, this is just a nice infographic on water over the lifespan. You can see as we age, our total body water percentage decreases from about 80% down to about 40% at the lowest when we get to older adults. It's important to keep in mind with your older adults because they are more sensitive to shifts in our body water balance, whereas children and uh, babies tend to have more water. So, why do we need water? Um, it is the basis for blood, lymph, and serous fluid. Water transports gases and nutrients and waste products. Water is needed for chemical reactions to allow muscles to function and neurons to fire. It flushes waste products through the kidneys and the GI tract. And water, depending on what's it dissolved in, can act as a base or an acid to maintain our acid-base balance. Now, this is one of the more complicated concepts to understand. And this is one that you really do need to have a thorough understanding of is the fluid compartments. There are two primary places in our body where fluid collects. That is inside the cells or intracellular fluid or ICF, and outside the cells, which is our extracellular fluid or our ECF. Okay. Now, our fluid within our cells, our ICF, that is the majority of our water. The majority of our water balance should be inside our cells. Okay, about 2/3 of our total fluid is inside our cells. Even though there are more places outside the cell for water to go, the majority needs to be inside. Okay, now the rest of the fluid outside the cells is further broken up into our interstitial space. Okay, and that's fluid between cells in our lymph system. Our intravascular, which is our plasma. Okay, remember blood is broken up into white blood cells, platelets, red blood cells, and plasma. So our intravascular is mainly water. And then our transcellular fluid, that is fluid inside our GI tract, our CSF, our cerebrospinal fluid, um, fluid inside our joint spaces, or our peritoneal cavity. Okay. All right. So here's just another infographic of fluid compartments. So again, the majority of our fluid is inside our cells. Then we have some interstitial fluid, we have and plasma. So calculation of fluid gain or loss It's important to note that 1 liter of water weighs about 2.2 pounds or 1 kilo. Okay, so body weight change is an excellent indicator of overall fluid loss or gain. It is why a patient needs to be weighed daily. Daily weights are the absolute best way to predict if water is being lost or gained. So, movement of fluid throughout the body. Like I mentioned, in order to maintain homeostasis, fluid must be constantly on the move. Now, the osmolality of the fluid surrounding the cells, remember the majority of the water is inside the cell. The osmolality of the fluid outside the cells actually affects them. So we have three types of fluid. We have isotonic, hypotonic, and hypertonic. Uh, Within our body system, these are also fluids that we can use to replace uh, if we have a fluid imbalance or an electrolyte imbalance. So to look at how these impact, let's take a look at a red blood cell. So again, you've got your cell here. Now, iso means the same. So a red blood cell inside of an isotonic solution, there's absolutely no change in the cell. There's no change in shape or structure. There's no fluid movement in or out of it. Now, that same cell, red blood cell or any others, placed in a hypotonic, so less than solution, will actually swell. Okay, fluid will move into the cell. Now, a hypertonic will have the opposite effect. The cell will shrink and fluid will move out of it. So, when you think about the state of hydration in a patient, whether or not we give a hypotonic, isotonic, or hypertonic depends on the balance of water they already have and what our intention is with administering that fluid. Do we want cells to remain the same? Do we want cells to grow or do we want cells to shrink? This is table 16.2 out of your Lewis text. It is a breakdown of our normal fluid balance in the adult. You can see this is an excellent visual for why balancing our intake and output is so important. In general, the average adult takes in about 2,500 mLs. And in general, the average adult loses about that much. Now, take a look at our output here. We have insensible loss, that is from our skin and lungs. Breathing actually increases our insensible loss. We do lose some normal fluid in our feces, in our stool, and then the majority of our output is in urine. Okay, so when you are reviewing this, think about things that might increase our insensible loss, and we'll talk about that in class. So fluid spacing. Fluid can move out of the cells abnormally, and when there's a change, it changes the spacing of our fluid. Again, remember the majority of our fluid should be inside our cells. This is called first spacing. That is the normal distribution of fluid in the intracellular and the extracellular compartments. Okay, everything is hunky-dory with first spacing. Now, in situations where we have fluid move outside of our cells and we have additional fluid in our interstitial space, we call that edema. And this is an example of second spacing. Fluid moves out of the cell becomes dehydrated, and fluid is now in between the cells. So in cases where we can see the edema, like in our lower legs, you then have swelling. Okay. Now, third spacing occurs when fluids collect in the non-functional areas between cells. This fluid is trapped. In cases like this, there's nothing that we can do other than go and get the fluid through like a procedure to get it out. There's no way for the fluid to move back into the cells. Ascites in liver patients is the most common example we use for third spacing. I cannot give any medication or do any procedure that will force fluid that is collected in the abdominal cavity back into the cells. The only way to get rid of that is to actually tap the belly. It's called a paracentesis, and we drain that fluid out. Now, second spacing, again, we've got that abnormal fluid in our interstitial. That fluid can actually be pulled back into the cells and into our vascular space to be excreted. There's a number of different ways that we can do that, and we'll look at some examples of that. All right, so how does fluid move throughout the body? There's a whole mess of ways the fluid can move. The first one here, diffusion. This is passive movement from an area of high concentration to low concentration. Uh, the thing about the passive is it requires no energy and it will occur on its own. Now, facilitated diffusion is the same thing, it's passive. The difference is there's now use of a binding molecule to a protein carrier. An example of this is the movement of glucose into a cell. Glucose is too big of a molecule to move on its own, so it will bind with a carrier and it will move across the cell membrane. Again, no energy is needed for this, it's passive. Now, active transport, there you go, you've got that active word, that requires energy. This example of here would be molecules moving against a concentration gradient that cannot happen without some sort of chemical reaction or energy use. The most common example of this is the sodium potassium pump in your muscles. Now, osmosis is the movement of pure water down a concentration gradient from a low soil concentration to one of high. Notice it's backwards from diffusion. Okay. Uh, Osmosis requires no outside energy sources, but will stop when the concentration differences disappear, or there's balance, or when hydrostatic pressure builds and opposes any further movement of water. Osmosis is what happens when we have changes in our blood pressure and then we end up with edema. So, what is hydrostatic pressure? Oh, these are just a couple of visuals for you. So, hydrostatic pressure, um, in short, is our blood pressure. Okay, it's the pressure inside of our blood vessels, and it's generated by our heart. We will get into hypertension and what changes our blood pressure at a later time. And now, at the capillary level, hydrostatic pressure is the major force that pushes water out of the vascular system and into the interstitial space. So, think about what would happen when we have gross changes in our blood pressure. What do you think happens at the capillary level when our blood pressure is exceptionally high? On the flip side of that, what do you think happens at the capillary level when our blood pressure is very, very low? Okay. Now, oncotic pressure is the osmotic pressure caused by our plasma colloids in a solution. In blood, so oncotic pressure works just like hydrostatic pressure within the vascular system, but instead of a pressure that's being created by a pump, like a heart contraction, this is now pressure created by a protein. Okay, remember proteins are like little water magnets. They collect and pull water back into the vascular space. The most common protein that we talk about is albumin. So when albumin is low in the blood, water will seep out of the vascular system. We can actually administer additional albumin to pull water back into our vascular system. So both hydrostatic and oncotic pressure work within our vascular system to help regulate where our water is. Uh, the thing about hydrostatic and oncotic pressures is they don't have any impact on the overall fluid volume balance of the intracellular space. So they cannot change whether or not our cells themselves have too little or too much water. This is very much our vascular system. So, how do we regulate our water balance? Our hypothalamus is our primary, and that stimulates our thirst. So, when we are low, our body says, hey, we're thirsty, and we drink. Now, renal regulation, the primary organs for regulating our fluid and electrolyte balance, they will adjust our urine volume based on indicators throughout our body, whether or not we're dry or we have too much. There are other sites of regulation, but that is not the primary purpose of this presentation. So know that in an adult with a functioning renal system and a functioning hypothalamus, dehydration is uncommon. Okay, we should have thirst that activates, and then our kidneys adjust based on our water level. But when we have disruption in our thirst or our kidneys are not functioning, it can lead to either deficits or excesses in our fluid volume. So, what are causes of fluid and electrolyte imbalances? Two primary categories here. We can have uh, impacts directly caused by illness or disease. Vomiting, we are directly losing fluid. The same with diarrhea. We are directly losing fluid and electrolytes. Heart failure, kidney failure alters the way that our pumps work, alters the way that we regulate our fluid balance. This could also be a direct result of therapeutic interventions. If you give somebody too many IV fluids, they are going to have a fluid volume excess real fast. The same with diuretics, things like furosemide. If you over administer furosemide, a patient is going to dry up like a raisin real fast. So, our balance here, we have fluid volume deficit, hypovolemia, and fluid volume excess, hypervolemia. Okay. It's important to note that fluid volume deficit and dehydration are not the same. Dehydration refers to the loss of pure water alone without the corresponding loss of sodium. Now, fluid volume deficit, you should have a change in both your sodium and your fluid balance. And we'll revisit this when we do sodium here in a few minutes. So, fluid volume deficit, FVD, abnormal loss of body fluids. This could be an increase in insensible loss from fever or chills, inadequate fluid intake, perhaps you're lost in the desert. Plasma shifts in our plasma to the interstitials, burns, or perhaps a total loss uh, of plasma and red blood cells and hemorrhage. Now, fluid volume excess, hypervolemia, this could be an excess intake of fluids or IV. Those are not as common. Those are not as common. Uh, Usually, a fluid volume excess is secondary to a disease, either heart failure or kidney failure, where you have abnormal retention of fluids. Okay. Most commonly secondary to those. So, when we think about assessment of our patient, here's just some general thoughts to consider. Um, Symptoms of fluid and electrolyte imbalance are often nonspecific. You have to consider symptoms in the context of the risk factors present. So think about your overall patient. Are they elderly? Are they homeless? Do they have heart failure? Do they have kidney failure? Do they have vomiting, diarrhea? Do they have unexplained nausea or fatigue or dizziness? Are they short of breath? Is their blood pressure low? Is their heart rate high? Do they have cramping? Do they have edema? Do they have sudden changes in weight? All of these things together lead you to, do they have fluid excess or deficit? Do they have an electrolyte imbalance that we need to identify and correct? Um, do we need to intervene on their fluids in some form, shape? So, things you will see when you've got a fluid volume deficit. This is again your hypovolemia. They're going to be restless, drowsy, or lethargic. Okay, they're going to be a neuro impact. They are going to be thirsty. They're going to have dry mucous membranes, so cracked lips, dry mouth, dry tongue. Uh, They will have cold and clammy skin. Remember, when we don't have the circulating volume, we are going to have vasoconstriction, and then our skin is going to get cool. We're going to have a decreased skin turgor. So you're going to see that tenting when you pinch, a decrease in cap refill. They're going to have hypotension. They're going to have an increased pulse and a decreased central venous pressure. They're going to have a decreased urine output, and any urine that they do produce will be extra concentrated. They're going to have an increase in their respiratory rate, which further increases our insensible loss. We make ourselves worse. They may complain of weakness. You might see a weight loss. Remember that fluid liter weighs 1 kilo. Seizures, coma, up to and including seizures and coma. Now, labs, you're going to draw your labs. You're going to have an increase in your serum osmolality. It's going to be more concentrated. You're going to increase in your BUN. It's important to note that you're going to have an increase in your BUN without a corresponding increase in your creatinine unless there is already pre-existing kidney issues. You're going to have an increase in your electrolytes. Okay, and generally this is a pseudo increase due to an increased concentration. Remember, we lose the water, everything concentrates. We're going to have an increase in our total protein, and we're going to have an increase in our hematocrit. Again, like the BUN, an increase in your hematocrit without the corresponding increase in our hemoglobin. Our hemoglobin will be stable and our hematocrit will be high. Now, for our fluid volume excess, patients often complain of the same things: headache, confusion, that lethargy. But now you're going to see difference in physical findings. You're going to have peripheral edema, that pitting edema. You're going to have jugular venous distension. Uh, that we will discuss how to measure JVD. It's usually not done correctly out there in the real world, but you will be able to see an increase in the jugular veins in the neck. They will look like big, they will look distended. You may have an S3 heart sound. That's an extra heart sound above and beyond our S1, S2. You're probably going to have a bounding pulse. You're going to have an increase in blood pressure and an increase in central venous pressure. Polyuria is an excess of urine output. So you're going to have uh, an increase in our urine output, and urine is going to be very, uh, the osmolality is going to be low. It's going to be very almost like clear, like you're peeing water. Uh, Patients may complain of dyspnea or shortness of breath. You might auscultate crackles, secondary to pulmonary edema, because now you remember if fluid is leaving cells, it's leaving cells everywhere. They might complain of muscle spasms because of a decrease in the concentration of our electrolytes. They might have weight gain. And just like in our deficit, up to and including seizures and coma. Now, when you draw labs, again, you're going to have a decrease in that serum osmolality. It's going to be very unconcentrated, diluted, or very diluted. You're going to have a decrease in your BUN, a decrease in your electrolytes. Now, it's important to note that your electrolytes are probably not truly diluted. They are truly lost. They are going to be diluted, especially your sodium. You're going to have a decrease in protein, again, due to dilution. You're going to have an increase in your brain natriuretic peptide, BMP. The BMP is really secondary to your heart muscle, recognizing an increase in overall plasma. Okay, it's basically your heart releases BMP saying, help me, there's too much fluid for me to handle. You can look over your nursing diagnoses here. Nursing interventions, first and foremost, daily weight. If they've got a fluid problem, you're getting a daily weight. How do we weigh our patients? Same scale, same time of day, ideally in the nude. Now, most patients in the hospital don't want to strip down for you, so make sure that they're only wearing a gown. But when you teach them to take their weight at home, which you will teach them, same scale, same time of day, ideally in the nude. Okay, eyes and O's, strict eyes and O's. Labs, telemonitoring, fluid restrictions. or fluid therapy, depends on what the patient needs. So, a couple of things about fluid therapies. First and foremost, if they can take oral fluids, we give oral fluids. They must have the ability to swallow, express thirst, and have a functioning GI tract. We want to correct mild fluid and electrolyte deficits. Uh, Water, glucose, potassium, sodium. If you haven't looked at a bottle of Gatorade lately, that's a bottle of Gatorade. Now, if patients cannot take oral fluids, we will do intravenous fluid replacements. We do that for two primary reasons, either maintenance, when our oral intake is not adequate, okay, or replacement when losses have occurred. So, again, maintenance or replacement. Now, our type of fluids are categorized by tonicity. Remember, we talked about that, the isotonic, hypotonic, hypertonic. So, we're going to look at some examples. Now, there are a whole mess of examples in your textbooks and resources, even in your ATI. I would like you to stick to the ones listed in this PowerPoint to make it easy on everybody. These are the most common that you'll see. Now, our isotonic IV fluids. Uh, it is important to note they expand only the extracellular spaces. Okay, there is no net loss or gain. Ideal to replace volume deficit. Okay, these are our replacement fluids when we've had a loss. Okay, the two most common that you're going to see are 0.9% sodium chloride, also known as normal saline. Okay, the other that you're going to see is lactated ringers. Now, lactated ringers is the preferred fluid for large volume replacement. When I say large volume, I mean 3, 4, 5, 6 liter replacement. Okay, you might have individuals that are that dry that you need that much replacement. The reason being is lactated ringers um, will prevent the patient from developing acidosis. Sodium chloride in large volumes, again, 4, 5, 6 liters, that will actually shift the patient and they will into a state of acidosis. They will become very acidic. LR prevents that. Okay, so if you're giving a single bolus of 1 liter or bolus of 2 liters, sodium chloride perfectly fine. But when again you get up into those high, large volume replacements, you're going to need lactated ringers. The memory trick I like for that is think LR for the OR and the ER. Okay, so where do we give massive fluid replacement? In the operating room and in the emergency room. So those are your two isotonic fluids. Remember, those are your replacement fluids. Now, our hypotonic fluids, these are our maintenance fluids. We really don't have a loss going on at the moment, but perhaps the patient's oral intake isn't adequate to maintain hydration. So now we administer maintenance fluids. They're more water than electrolytes. Okay, you can see here our isotonic is 0.9. This is 0.45 sodium fluoride. This is also called half normal saline. Okay, water does move when we administer hypotonic fluid. So water will move from the extracellular to the intracellular. Okay. These are most often used to supplement oral intake, pre-op, post-op when patients are NPO. Perhaps they've had stomach surgery and they can't take in large amounts. We'll give either half normal or 5% dextrose. Now you're thinking, glucose, doesn't that make us, isn't that a water magnet? Doesn't that make us thirsty? In states of 5% dextrose, that 5% is metabolized so fast that what is left is basically water. So our third fluid here, our third crystalloid, is going to be hypertonic fluids. Okay. Now, hypertonic fluids are not standard. They are not a fluid that you administer. They're not one of our replacement fluids or our maintenance fluids. Our hypertonics are treatments. We use them only to treat conditions of either exceptionally low sodium. So we would give hypertonic saline, or in cases we have uh, an excess of water somewhere. Okay. Because initially it will expand and rise our osmolality. So if you were to give too much of a hypertonic IV fluid, you will actually dehydrate the cells in the body. Okay, so we need to monitor blood pressure, lung sounds, and serum sodium levels. All right, again, hypertonic fluids are given as a treatment. You need to think of hypertonic fluids as a medication, not as a fluid you're going to administer. Hypertonic saline is actually so dangerous, you really only give it in small, teeny tiny amounts, 50 mLs at a time. Okay, so our plasma expanders. These are our colloids. Our previous three are crystalloids. These are our colloids. You're going to see a lot of these in practice. Albumin, remember we talked about albumin is our primary protein. We can actually administer albumin to individuals in order to pull fluid back into our vascular space. This is very common in states where a patient has fluid volume excess and they're dehydrated. It is entirely possible to have both. Uh, Bad heart failure patients, we give albumin. Liver patients who can't process protein, we give albumin. Okay, the other example of that is FFP, or fresh frozen plasma. When you donate blood, your blood is broken down into platelets, plasma, and red blood cells, and they can be administered to different people. One unit of donated blood can go to 4 different people, depending on how it's broken down. Now, dextran and hetastarch are not common outside of the ICU. There's a good possibility you will not see these very often. Blood, packaged red blood cells, we get blood all the time. It's a plasma expander. Just so you know, albumin sometimes comes in a bag and it is that awful color yellow. More often, though, it is going to come in a glass jar and it will be crystal clear. Okay, let's talk a little bit about electrolytes. And there are a whole mess of electrolytes in your body. We have 2 exemplars we are going to focus on in this course, and that is sodium and potassium. I would like you to know the normal values of the others, but with sodium and potassium, you are going to understand highs and lows, signs and symptoms of each, and what causes each of them. So sodium, 135 to 145. Lewis text states normal is 136 to 145, perfectly acceptable for both. Um, what is the purpose? Our acid-base balance regulates our chloride, influences renal excretion of H2O. Remember, water follows salt, so the more salt we take in, the more water we retain. Anybody who's ever overdone it with the chips and salsa knows that is 100% true. And it creates a charge in opposition to potassium because, again, we need, in order for our muscle functions to work, we do have to have our positive electrolytes. All right, so hypernatremia. Natremia, cases of high sodium. This is a sodium level greater than 145 milliequivalents per liter. Um, in the average adult, high sodium, not a problem. Our body regulates and dumps our sodium back out. It becomes a problem again when we have a change in our intake. So either a neural dysfunction, it changes our thirst, or we don't have access to water. So causes cases of dehydration. NGT is a nasogastric tube suction. Pull everything out of somebody's gut, you're probably going to dehydrate them and their sodium is going to concentrate. Okay. We expect in cases where our sodium concentrates like that, that when we administer fluids, the sodium will normalize. What we mean by drains are there are cases where in post-operative patients, we will insert drains to drain away exudate and fluid. With that, drains off fluid, our sodium concentrates. Fevers, again, insensible loss, we lose water out of our skin, we don't lose the sodium. burns, and then diarrhea. Assessment findings: AMS is altered mental status. You want to think natremia, NA, neuro. It's going to have an impact on our neurosystem. Both states of high and low sodium will cause a neurological dysfunction. Okay, really bad cases of high and low sodium will lead to seizures, muscle twitching. It can lead to decreased cardiac contractility, but you're going to have those neuro symptoms first. Uh, you're going to be thirsty and you're going to have those dry, sticky mucous membranes. Interventions: cardiac monitoring, seizure precautions. That means patients can't get up and move around. You need to pad bed rails and have suction and oxygen bedside. Vital signs routinely, strict I's and O's. And in cases of high sodium, we want to give IV fluids that do not contain any sodium. So we're going to give a hypotonic solution of dextrose 5% in water. Okay, so high sodium, you're given D5W, D5 in water, dextrose in water. Just an infographic you guys can look over. Now, hyponatremia, this is low sodium. This can be a sodium less than 135. Okay, causes hypervolemia. Now, notice that one's marked there. There are two states of hyponatremia that you need to pay attention to. The first is a case of dilution. If we have hypervolemia and we have fluid volume excess, our sodium is not low, our sodium is diluted. Okay, so in cases where we have fluid volume excess, we do not have a true hyponatremia. We have a dilution effect. And when we concentrate that fluid volume, we pull that extra fluid off, our sodium should normalize. Psychogenic polydipsia is a neuro disorder in which patients cannot control their thirst, so they drink constantly. I've never personally cared for one of these, but I did have a coworker who did, and we had to have the water shut off to the room in order to keep her from drinking out of the sink and out of the toilet. Diuretics, an excess of diuretics, you will lose sodium. Burns, notice burns could cause hyper and hyponatremia. It depends on what stage of the burn that you're in, the amount of tissue that was damaged, whether or not we will lose with wound weeping or whether or not we will gain with massive dehydration. And then poor sodium intake. In developing countries, this is not an issue. Now, assessment findings, again, think natremia neuro. You're going to have an altered level of consciousness and altered mental status, confusion, seizures, weakness. They will complain of abdominal cramps. Interventions, I's and O's, seizure precautions. In cases of low sodium, now we are going to give 0.9% sodium chloride, so our normal saline. It's an isotonic. In cases of severe low sodium, uh, where patients have actual neurological symptoms, we may administer small amounts of that 3%, that hypertonic. It's very, very important that we monitor vital signs. We listen to heart sounds and lung sounds, monitor other electrolytes, and perhaps put them on a cardiac monitor to monitor cardiac function. Um, Patients with low sodium, we need to be very careful with our diuretics because we will actually make it worse. Okay, and just like before, our big complication is seizures and coma. And then a little infographic here for you. Okay, so potassium, our other electrolyte that we're going to cover, we've got 3.5 to 5 is our normal. Purpose, transmit nerve impulses, exceptionally important in cardiac contraction and skeletal muscle contraction, contributes to our acid base balance and contributes to our insulin, regulates our insulin and glucose storage. So hyperkalemia, high potassium, potassium greater than 5. Okay, it's important to note that the most common cause of high potassium is renal failure, the absolute most common cause. Other causes include acidosis, excessive intake, which is not common, ACE inhibitors can lead to high potassium. You have to monitor potassium levels in patients taking ACE inhibitors. Burns, fever, and crushing injuries. The reason crushing injuries and burns contribute to high potassium is they cause cellular destruction, and when the cell explodes, potassium is released into the serum. Okay, so whenever you have a state where there is cellular destruction, potassium is released. Assessment findings: irritability, abdominal cramps, weakness. The big ones is your cardiac arrhythmias. You are going to have cardiac arrhythmia before the patient has other signs and symptoms. Memory trick for that: remember cardiac. Okay. If you have an abnormality, high or low potassium, you need to get that patient on a cardiac monitor and need to monitor for abnormal heart rhythms. Okay. You may see in really bad cases of high potassium hyperkalemia, you may see what's called a peaked T wave, and we will explore that later in the term. So, couple of ways to treat high potassium. Unlike sodium, which is treated by regulating our fluid balance, potassium has to be directly treated. Okay, there's a couple of different ways to do that. The first one is regular insulin and dextrose. Okay. You administer insulin IV push to a patient. Note that it's IV push, not subcutaneous. Uh, and then you follow that with D50 or dextrose 50%. That is basically sugar dissolved in water. Uh, and what happens is the insulin will force the potassium back into the cells, and then you administer the dextrose to prevent a drop in blood glucose. Okay, this is a temporary fix. This will force K back into the cells, but we need to fix what was ever causing the hyperkalemia. Okay, this is a really great intervention for patients who we can fix what the issue is. Okay, now this medication, Kxalate, that is an excellent option for excreting the excess potassium. Uh, what's nice about Kxalate is it is available for patients to take at home if necessary. Uh, in order for Kxalate to be administered, you have to have a functioning intact GI tract, because what it does is it pulls potassium into the GI system and then is expelled with the stool. Now, it's important to note that Kxalate will aggravate our GI tract a little bit. And what happens when we aggravate our GI tract? We get a little diarrhea. So you need to monitor the patient's fluid volume as well. Kxalate can be given orally, or it can even be given as an enema to patients who cannot swallow. But the important thing is they must have an intact GI system. Okay. Patients absolutely have to be on cardiac monitoring. Uh, there's too great a risk for sudden cardiac death if we're not monitoring our potassium. Uh, we need to monitor diuretic use and make sure that we're giving an appropriate diuretic, monitor vital signs, other electrolytes, and note that one of the reasons we do dialysis in patients and inpatients is high potassium. Potassium greater than 7 almost guarantees that a temporary dialysis catheter will be placed and the patient will go for dialysis. The risk: sudden cardiac death. There's a little infographic for you. On the opposite end of the spectrum, we have hypokalemia, low potassium. Causes: big one, loss, nausea, vomiting, diarrhea, diuretics. We lose a lot of potassium with our diuretics. If you've got a patient taking a diuretic, you've got to keep an eye on that potassium. Diaphoresis, alkalosis, poor intake, and excessive insulin use can also lead to low potassium. Assessment findings are complaining of fatigue, weakness, bradycardia, irregular pulse, maybe that numbness, tingling in their fingers. Okay. The big thing is, just like high potassium, you're going to see cardiac arrhythmias. Okay. You are going to see them. Interventions: we've got to give potassium. We've got to replace it. Now, potassium can be given IV or orally. Okay. Um, they've got to be cardiac monitored. You've got to monitor vital signs and you've got to monitor our other electrolytes. Now, I want to take a moment just to talk a little bit about giving potassium to somebody. Um, KCl, potassium chloride supplements, again, you can give them orally. Orals come in pills, powders, and liquids. Uh, don't let your patients chew up the potassium pills. I know they are gigantic. They look like horse pills. Perhaps you've already seen them in clinical, but they taste like acidic chalk. It's not good for our GI systems to chew those up. If the patient can't swallow the pill, ask the pharmacist if we can switch to a powder that can be mixed with like applesauce, or if they can take the liquid, the pre-made liquid. Now, if you're going to give potassium chloride through an IV, it absolutely must be on an infusion pump. Under no circumstance ever will you ever push potassium chloride as an IV push. To drive this home, potassium chloride is one of the drugs used in lethal injection. You will kill your patient. Okay, you do not give potassium chloride IV push. It absolutely must be on an infusion pump and it must be given slowly. Okay, this happens. It happens often. All right. So there. All right, so we ended a little dramatically there, but I think I drove our point home. Please do the ATI fundamentals on fluid balance. Remember, we are not covering acid base. You do not need to do that section in either the textbook or in the ATI fundamentals. So please focus on your fluid balance, your volume and excess, what causes it, what the assessment findings are. When you were studying that, think about what does somebody look like who is in fluid volume excess? What does somebody look like who's in fluid volume deficit? And then closely study your sodium and potassium. Remember to know your two C's, your causes and your consequence. What causes hypo and hyperkalemia and hypo and hypernatremia? What are the consequences of those? Uh, enjoy your lecture and we'll see you in class. Thank you.